So Dr. Petropoulos will present next on the clinical presentation of aortic valve disease, stenosis and regurgitation.
So, dear colleagues, when we discussed to put this topic on, Professor Kalangos exists to put the topic because we are now going to a period in which imaging and all the other data we have makes us forget how important is the clinical factors of the patient. So I have the honor now to present this talk. Okay. So it must be this. Yes. It was a great honor for me when Professor Kalangos chose me to be the secretary of the Balkan Society, and I want to take this opportunity to thank him and also all the members of the Balkan Society, and I believe that after this conference we will get more members in our society. The topic is clinical presentation on the aortic valve. I have no financial disclosures. The aims of my presentation as seen in this slide, and I'll start telling you that aortic valve stenosis, as all we know, is a narrowing or a restrictive opening or an obstruction in the flow of the left ventricle to the ascending aorta in systole. And aortic valve regurgitation is an incomplete closure causing a backflow from the ascending aorta to the left ventricle in diastole. We can also have mixed forms in which we have either the superiority of stenosis versus regurgitation or regurgitation versus stenosis. The prevalence of congenital aortic valve stenosis is quite high if we take in consideration the bicuspid aortic valve is the most common congenital heart disease. And we have studies of prevalence in which we can find from 0.5 to 2% of the general population people that are born with bicuspid aortic valves. Now, as all the bicuspid aortic valves have a pathology at birth, not all of them, but we will see that a significant amount of stenosis coming up to 0.5% of the general population may have a mild stenosis at birth. It affects mostly male, as you can see, and it comes up for the 3 to 6% of all the congenital heart disease. It can be associated with coarctation, with a perimembranous VSD, with interrupted aortic arch, with hypoplastic left heart syndrome. It can progress to dilatation of the ascending aorta, leading to an aortic dissection, and some syndromes like Marfan's, Ehlers-Danlos, and Schoen complex have an element of a bicuspid valve or an aortic valve stenosis. Now, we have also acquired stenosis, either secondary to a bicuspid valve or other conditions. And the most common condition is what we call the aortic valve sclerosis, seen in 25 to 45% of all adults age over 65 years old. Congenital aortic valve regurgitation can be found in the 0.3% of the general population, and it's more frequent if you have a bicuspid aortic valve. Newborns, have non-trivial aortic valve regurgitation up to 13% if they have a bicuspid aortic valve, and also a larger aortic dimension at birth. Commonly, we can see in aortic regurgitation perimembranous VSDs and Marfan syndrome. Going to the etiology, as we said, congenital aortic valve stenosis is the most frequent condition under the age of 70 years old. Aortic valve sclerosis is very high after the age of 65 years old, and mostly in patients that have a high element of LPA lipoprotein. Now, secondary issues to aortic valve stenosis is psoriasis, endocarditis, and rheumatic heart disease. Although we don't have rheumatic heart disease in Europe, we must remember that worldwide we have about 39 million cases and over 300,000 deaths per year. Coming to the aortic valve regurgitation, you would see that congenitally the etiology is about 10% in patients with bicuspid aortic valve. Dissection of the aortic, of the ascending aorta in 20% of patients with a bicuspid aortic valve. Endocarditis is also a very common etiology for regurgitation. Myxomatous degeneration of the cusps of the valve. Rheumatic heart disease, 17%. Lundry-Pesi syndrome, a condition with a specific type of a perimembranous VSD with an aortic valve regurgitation. Trauma of the ascending aorta, genetic syndromes like Marfan, Ehlers-Danlos, autoimmune conditions like systematic lupus erythematicus, or ulcerative colitis, rheumatoid arthritis, psoriasis, and giant cell arthritis, and other conditions like osteogenesis imperfecta and Takayasu disease, or etiology of acquired or secondary aortic regurgitation. Now, as we know, our specialty deals with different age groups, and in each age group we have a different pathophysiology and a different clinical presentation. Starting now for the pathophysiology of an aortic valve, starting from the fetal life, it can be just a congenital aortic valve stenosis with a severe form of a bicuspid aortic valve with a coarctation or an interrupted aortic arch, leading to left ventricular fibroelastosis, as you can see on the slide of the echo over there. Or it can be just a hypoplastic left heart syndrome that has a different outcome. Childhood and adults, moderate to severe stenosis. Left ventricular will have a concentric left ventricular hypertrophy, and gradually this hypertrophy will also accumulate to aortic valve regurgitation that will drop the ejection fraction, and it will create a dilatation of the ascending aorta and a condition in which we have this entity, the clinical entity, where we have a severe aortic valve stenosis with a low-grade ejection fraction and a low-grade between the left ventricle and the ascending aorta, plus mitral valve regurgitation. The pathophysiology of the aortic valve. Acute aortic valve regurgitation, the left ventricle has no time to dilate, and we have an acute dilatation of that will create dilatation of the mitral valve ring apparatus, and we will have congestive heart failure and drop of the ejection fraction. Finally, we will have a post-capillary pulmonary hypertension in the pathophysiology of these patients. And in chronic aortic valve regurgitation, there we have a gradually volume overload, normally left ventricle pressures, and a normal ejection fraction is maintained for quite enough years. But this will bring a condition up where we will have left ventricular dilation and left ventricular hypertrophy. And when this decompensates, we will have arrhythmias, heart failure, and pulmonary hypertension. Clinical presentations, as I said, in fetal life, in the severe form, we will have low cardiac output syndrome, failure to thrive, congestive heart failure, and poor outcome. In the childhood, with a moderate to severe form, we will have exercise intolerance. As the child grows, some pre-syncope or syncope attacks, arrhythmias, sudden cardiac death syndrome can be seen in these conditions as the stenosis accumulates to more severe condition. Now, we have a very good clinical approach to these patients because, as all of you know, they have this systolic crescendo-decrescendo ejection murmur, a single-second sound, an injection click when we have a bicuspid aortic valve, and typically this increases when the volume of the left ventricle increases and decreases when the volume of the left ventricle decreases. In an adult severe form, we will have problems like angina, syncope, short of breathness, congestive heart failure, arrhythmias, and sudden cardiac death syndrome. Similarly, in the fetal neonatal severe form of aortic regurgitation, low cardiac output syndrome, failure to thrive, congestive heart failure, and a poor outcome. In childhood, as I said, a moderate condition of regurgitation can create, in the beginning, exercise intolerance, later syncope and arrhythmias, and sudden cardiac death also. Also, the clinical examination in these patients is very decisive for the diagnosis because although the child can be asymptomatic, when you examine the child, you will find this low in high-pitched diastolic decrescendo murmur, and also you will be able to hear the diastolic apex Austin-Flemm murmur that these patients have with a widened pulse pressure condition. In adult form of severe regurgitation, the symptoms that present are similar to aortic stenosis. Now, I put these 4 elements of clinical presentation to remind to you that we have the Corrigan sign, as you can see over here. Okay, sorry, I couldn't find the, okay. The Corrigan sign, as you can see the pulsation of the carotid artery. You can see the pulsation on the tips of the nails. You can see that the moose sign in which the patient with severe regurgitation moves and bumps his head every time you have a pulse. And you can see also the collapsed pulse condition. When you pick up the hand of the patient, the pulse diminishes. Supporting evidence will come from a chest X-ray and an ECG, both in both conditions. And I'll pass these quick because we want to make some time for the next presentations. The diagnostic approach will be age-specific on the medical history and the physical examination. An X-ray and an ECG always helps. For the imaging, the next presentation will discuss all the topics of the imaging, and also functional tests can give us evidence and conditions in which we will need to step up or wait for our further procedure. Treatment options based on the age and gender, if we want to proceed with a pregnancy in a female patient, on symptoms, and on the finding of imaging and functional tests. Now, 2 words just for the natural history and finishing this presentation. Congenital severe stenosis goes through in fetal life to the hypoplastic left heart syndrome and will have a poor outcome as we have discussed until now. Congenital mild bicuspid aortic valve has a slow progression. It will become symptomatic nearby 40 years old. In congenital bicuspid moderate stenosis, treatment plans must be done, okay, nearby, not existing the 45-year-old age of the patient. And in degenerative aortic valve, untreated severe symptomatic stenosis over 60 years old is fatal, and every 2 years the mortality raises by 50%. In chronic congenital mild or moderate regurgitation, we have a slow progression of the disease. Okay, by 30 years, it will be symptomatic. By 40 years, you need to have treated these patients. By 50 years, if patients are untreated, they will have heart failure, arrhythmias, and death. In congenital severe regurgitation, we have a rapid progression, and the treatment must be done in the first 10 or 20 years of the patient. In congenital acquired mixed form that can be moderate, with more regurgitation than stenosis, in 10 years we have symptoms, and up to 15 years we need to have treated all these patients. And finally, in congenital acquired mixed form with severe regurgitation, this is symptomatic in the first year of the child, and treatment must be done in the first 3 to 5 years of the age. The take-home message is that congenital aortic valve disease is a very common condition. Congenital severe form in fetus and infant is an urgent condition. Degenerative severe forms of aortic valve over the 70-year age may be lethal. Congenital severe aortic regurgitation is rare, and we can only see this in 0.4% of all congenital heart disease. Congenital acquired severe acute regurgitation, plus or minus a mixed form, is an urgent condition. Both nosologies have an easy diagnosis, many forms of treatment related on age, symptoms, anatomy, and physiology, and digital diagnosis, thorough follow-up, and appropriate timing treatment is the base to success and health to these patients. Thank you, and I just finished 3 minutes earlier. And do we have any questions?
If there are no questions, I would just like to add the comment that clinical examination is key. The initial assessment of the patient is key to the selection of the appropriate test, imaging test, as a bridge to the next talk. Thank you.
Thank you. So we'll put a couple of minutes.
Can I have questions? Sorry.
Yes.
I have Andreas, tricky question. When to intervene in aortic regurgitation?
Well, if it's an acute congenital regurgitation.
You have a patient with bicuspid aortic valve, aortic regurgitation, or tricuspid aortic valve, isolated, no stenosis.
Yes.
When to intervene?
Okay, newborn.
No? 3 years old.
3 years
5
old.
years old. I'm not talking about critical.
Not critical. So I would go through with all the data I can get from imaging regarding the left ventricular outflow, and diastolic diameter and systolic diameter, and if any kind of other information from an X-ray or an ECG to determine when to
ECG
approach.
normal, left ventricle function brilliant, LV dilated.
So if LV is
So
dilated,
I'm waiting for your numbers.
So if LV is dilated,
How much dilated?
with a Z-score of +3
Why? Why +3?
or +2 even, somewhere between +2 or +3.
So this is really tricky, right? You remember the football player Kanu? His left ventricle was 68 millimeters before he went for Ross, and then he played still with the Ross. He played the Champions League, right? So this is a bit tricky. We did a study a long time ago, so we stick to Z-score +4 in context of the preserved ventricle function, because if you wait for the ventricle function to go down, it's too late. because apparently when you eliminate the aortic regurgitation, so then the left ventricle fails. So so it's difficult because when we discuss again, with all experts, so certainly +2, no, very happy, unless it's very rapidly progressive. So that's, the suggestion is to have the both echo MRI follow-up, but we would probably not intervene until the Z-score on both MRI and echo, it's around the +4 in context of preserved ventricular function.
Okay, can I ask now another question to you? Would you take in consideration the dilation of the ascending aorta or the root, even if the Z-score of the left ventricle is +2 or +1?
Yeah, but that's different story. So let's take the bicuspid aortic valve out of account. So we have the tricuspid aortic valve, let's say. Sergey.
My question is about Z-scores. Which Z-score? Because we use better for Z-score from Detroit. We cannot reach Z+2 even if we have that's not the after 70. In past few years, we use Boston Z-score. Do you agree that Z-scores are confident?
Well, difficult to say because now many places we replace the existing. Actually, I started with my Z-scores in 1980, and still the many institutions will stick to Leo Lopez Z-scores because they are based on the 8,000 volunteers. So that's the big number. We already discovered there is the problem with the coronary artery Z-scores. So we stopped using the Leo Lopez reference values for coronaries. But I think the most of the big units like GOS, we use the Leo Lopez Z-scores. But of course, what I did, because I implemented the Z-scores to our the electronic reports, you need to have, if you change them, you need to know, and we have the imperative in the system that we change the reference values from Boston to Leo Lopez and use on the longitudinal studies. This is important, yeah, because there are the differences. The largest differences goes to the small babies, even the premature born babies. It's difficult to stick on even the left ventricular diastolic dimension because, of course, the numbers are much smaller. But it's always you find, it's race, it's the issue, because the black people, they have the larger left ventricles, the myocardial mass, so there are always some limitations. But it's best is to stick to one and use to see the trend, how the left ventricle progress in dilating.
Thank you for the comment, and we can move now.